Today, I'm not alone. We're going to talk about core concepts of quality and safety. I'm joined by Lyle Sa. Did I say that correctly, Lyle?
Yes, that's perfect.
And can you say a little bit about you?
I'm currently a fourth-year medical student at University of Massachusetts, and I am very happy to be joined by Dr. Kadam. I'm very passionate about QI, so this has been a great opportunity for me to learn as well.
Okay, great. So we're going to go over core concepts of quality and safety. We read the ABR syllabus, and we're going to try to keep to that content a little bit. What is quality for you? Why is it important for you, Lyle?
I was introduced to the concept of quality through a mini QI project in medical school, and that kind of led me down a pathway of what is quality, what is QC, what's quality control, what's quality assurance, and how does that relate to QI, quality improvement?
Great. I like quality improvement as a discipline because it's important in any specialty. So if you ever change your mind and you don't want to do radiology anymore, that's a transferable skill and it's a really great skill set. I appreciated getting into quality improvement. It's a combination of leadership skills, problem-solving skills, teamwork, and improvement. You're doing something ultimately that's good for patients. So everything about it is just really stuff that I enjoy. The quality of care is unfortunately an issue. The goal here is to provide high quality care. What that breaks down into is doing the right procedure in the right way, at the right time, for the right patient, consistently. And that has to be aligned with patient preferences and has to be focused on good outcomes. So there are a lot of elements around what this quality improvement really is. Can you speak to the idea of consistency and excellence? What does that mean to you?
I think of excellence as kind of performance. When we are able to adhere to a high quality, it means that we're performing at a standardized way, meeting the evidence-based practice. That's where the consistency component, I think, comes into place. It's not only important to be able to meet these standards, but be able to meet it consistently and to be able to sustain it, which is foresight into another topic in this chapter.
Yeah, you said that really well. I couldn't have said it better. Sometimes we know what excellent is because we have the evidence that's already published and we have data to support that this is the best thing to do. And sometimes we just have from our daily practice an idea of what is the best way to do things. So those are best practices that are based on a very small evidence, which is our own evidence. If you remember, the evidence pyramid has several layers, and at the top of it, a systematic review of published literature. But at the very bottom is the local expert opinion. Do you know how when we practice, like I'm in an academic hospital, how would we put this excellence into writing? What is it that we have in place that guides how we practice? What do you think?
The first word that comes to mind is protocols and performance metrics and being able to meet those protocols. But I actually wanted to ask you that question.
That's good. So protocols is good. And then we actually have a whole set of policies that say exactly how you're supposed to do certain things in the safest and highest quality way. And when people deviate from the policy, they can actually get in trouble. That's a local policy we have at the hospital. That's not necessarily a state or federal policy, although there are those as well that we have to abide by. Of course, that's more severe when we don't do those. So we have policies, we have protocols and procedures and guidance documents. All of that lives in writing in a place that we call policy managers. So it's just an application where anybody can go in and find a policy or protocol or guidance or procedure telling them exactly how they should do something in certain situations. So what does our MRI screening look like? Or what is the checklist of questions we have to ask before we give IV contrast or when we test pregnancy? Then we have another set of written documentation that's not necessarily in the policy manager, but it's called standard work. Those documents actually write down exactly little processes, like how do you check that you have the right patient? So it would delineate that you call the patient by name, You check their ID by 2 identifiers, so at least the name, date of birth, medical record number. Those are standard work descriptions, and they describe every step in that standard work and how long it takes. People also have to conform with that. Those are all tools to force ourselves to perform excellently all the time and consistently. So once you have it written down, then it has to be consistent. Everybody does it the same way every time. In the ideal world, that should happen. We know in reality that doesn't really happen. You mentioned performance measures. Can you give an example of a performance measure, maybe for yourself as a medical student, or something that you've encountered in your QI project or in radiology, or that you can think of?
So, when we talk about performance measures or metrics, usually they are quantitative, something that can be data driven and then analyzed to see if there's improvement, consistency, something that we can obtain, see, and change. For medical students, I think the first thing that we are assessed on is our performance in exams, what score we get, how consistently we get it, and in what areas we get it in. The QI project that I worked on was what was the rate of surgical site infections. So it's a rate. It's again a number that's quantifiable, and there should be an average. There's a national average. So for medical students, there's a national average of test exams. For surgical site infections, there's an average and there's an ideal. So I think those are all reasons that drive it to be quantitative.
Perfect. And that's called benchmarking when you compare yourself to others. In radiology, we have some registries with the American College of Radiology where people can participate to enter their own metrics and compare with other institutions. Those are quantitative measures. I think you're right. They're probably more common. What are some barriers to getting those measures? You may have encountered some in your QI project.
I don't know if it's the most common, but what I've experienced is the culture behind wanting to disclose any information that may not reflect well on the institution, on the individual providers. Even as medical students, we don't want to expose ourselves if we don't get a grade score. So I think acknowledgement or exposure or sharing of that information is the first barrier we did face. And the second is, so we know the problem. What do we do about it was the next barrier of there's so many elements involved in that process that it's really hard to get to the root of the cause. Those were some barriers I've personally experienced.
Okay, yeah, we'll talk about root cause analysis at a later time. But in terms of the data, you're right. Getting the right data and then making the data accessible so that they can be easily retrieved are some of the barriers that I notice. We often have to create data manually, and that's not helpful when you want to give performance metrics at a larger scale. It should be something that's ideally completely automated. The automation includes retrieving the data, sorting the data in a meaningful way. For example, in radiology, when you're looking at turnaround time for the report, you want to be able to sort that by individual divisions and for each faculty member. And then you want to have graphic representations where individual faculty member can see the median for their peers and where they fall relative to the median. Then you have to have a feedback process in place. Somebody has to review this data. If just the radiologist sees it, that's good, but they might not do anything about it. But when their supervisor talks to them and says, hey, you are below the median, you should catch up, that is more meaningful. So we need to have that. Also, there needs to be documentation where the data is saved, including this determination that somebody reviewed it and did they take any action or not. And in a case where there's repeatedly a performance issue, there has to be a separate process for addressing that. If I coached somebody several times on their turnaround times and they're not improving, what is the next escalation step? Are they being called to the chair, or do they get something on their record? Are they losing their job? I don't know. In the current day and age where we're needing every radiologist, it's hard to lose your job, but performance is important and the data retrieval can be very difficult. Good. So we talked about excellence, consistency, performance monitoring. The syllabus talks about maximizing health outcomes that are desired by the patient and satisfy the patient. That's really nice that we bring in the patient perspective. What does that mean to you? Outcomes that are desired by the patient.
We want to do what's best for the patient. Usually that's the best outcome that we see in literature or what's most safe for the patients. We always talk about quality and safety together, but this new concept of these two words that you use, what the patient wants, so preferences, values, and patient goals, and prioritizing them, including them in the conversation. That's the core of patient-centered care. And what that means to me at this stage in my training means despite what we know, what is medically correct, best, optimized, we need to include the patients, let them ultimately drive the car and the decision because someone might not want what's best. They might want what's makes sense to their life, their lifestyle, their beliefs. If there's a strong religious belief, then we must adhere to it. But I think that has expanded. It's just a bigger, more comprehensive concept of what is best suited for what the patient envisions and wants.
Yeah, that's very good. You have a good idea there. For me, I look at the three elements. The patient preferences is different from the patient experience and the patient satisfaction. The preferences come in to me in decision making. There's this term of shared decision making, and that's really actually evidence-based practice where you bring in essentially three pieces of evidence. The provider has their own evidence from their practice, and the patient has evidence, which are their preferences. And then there's whatever's in the literature that we know is the best thing to do. So it could be that surgery is the best thing to do based on the literature, but the physician thinks surgery is not good because they're a surgeon and they've seen a lot of patients not get better with the surgery. And then the patient's preference may be to go for the surgery anyways because they're in so much pain that they're hoping the surgery will help them. And even at the risk that it won't help, they just want to give it a try. So that would be an example how these different elements come into the shared decision making. Patients' preferences can be motivated by a lot of things. Could be that they can't afford care that is being offered to them, so prefer not to spend the money and bankrupt themselves. It could be that they feel that they're old and they don't want additional treatment, or they have cancer and they don't want aggressive treatment. Do you know what the difference is between experience and satisfaction?
I can give it a try, but I don't think I have a evidence-based definition. I
Okay.
think experience encloses whether it was good or bad. It's how they perceive things, what they actually encountered and can describe. I think satisfaction is a metric that we present to them.
Yeah, that is pretty close. The way I try to remember the difference is satisfaction is about what you expect to be there and whether it's going to be there. When you have an appointment in radiology, maybe you expect there to be parking, you expect there to be a bathroom and the waiting area, and the waiting area should be clean and comfortable. And you expect your appointment to be on time, people letting you know when there are delays, people telling you what to do, people doing their job, and then you're being able to go home. Those are all the expectations when I come in for my exam. That's it. And then I can check off when I get the survey. Yes, it was the bathroom, it was clean, people talked to me, they were reasonably friendly, stuff like that. But the experience could be so different. Maybe the parking lot is there, but there are no signs telling you how to get to the radiology department. So you get hopelessly lost and you ask 10 people, how do I get there? And they give very rude responses. Nobody takes the time to walk you over there. Then you get there, there's a bathroom, but it's dirty. That's the experience of it. So that's a difference. And even though all the checklist items could be in place, the actual experience could be not so good. To me, as the more important piece is the experience, and people gloss over it because they can get very good satisfaction scores on the surveys, but when you think about the experience, it's often not that great. All right. And then the last goal before we end for today, is the desired health outcomes using methods that are consistent with current professional knowledge. So we already talked about this. Have you observed a lot of compliance with evidence-based practice? So when you worked with surgery, did you get the sense there was a lot of evidence-based practice?
I honestly think it was half and half, as in all providers started off with presenting themselves and the patients with, this is what the data shows. This is what these standardizing organizations recommend. And then they provided personal or experience based reasons behind it. So I think it was really a marriage between, this is the bare minimum standard knowledge, expertise that an organization has set, and then this is what I am doing with that. So it was a mixture.
Yeah, good. And then the patient can decide. That's the ideal state. In radiology, unfortunately, we as the radiologists know exactly what is the right thing to do, but we're not talking to the patient at that time when they're deciding to get imaging. It's some primary care provider or another specialist, and they may not have that same knowledge. So that's an interesting point in the medical journey where we're absent and we're trying to have input. There are systems like clinical decision support systems where when the provider orders a study, it gives them feedback whether for the clinical symptoms this is the right thing to do, whether they need contrast or not, or they should do something else, or they should do nothing. Sometimes there are indications where imaging is actually not needed. So that's good. And then the other place in radiology where the evidence base comes into play is when we interpret the imaging studies.
Yep.
For example, if we find an incidental lung nodule, there are actually guidelines, the Fleischner guidelines, that lay out exactly what features in the nodule inform a certain recommendation. So forget about this nodule, it's benign, or this is indeterminate, get the patient history, re-image the patient, or this patient needs to go to cancer screening, or this is so bad, they need a biopsy right away. There is evidence-based guidance for things like that, and that is important that we build that into our practice. Okay, good. We covered a lot in terms of the basic idea in quality improvement. And then we'll continue talking a little bit more about quality as a discipline. So for today, thank you so much, Lyle, and we'll continue our talk. Thank you.
Thank you.